Is this on? Yeah. Thank you, Chandima ma'am, and it's great to see such a wonderful audience. So my talk is on the neurological findings on OCT and visual fields that mimic glaucoma. I have a few interesting cases lined up, so hopefully you will forgive me for my cracked voice. So I'll present 6 very interesting cases. This is the first case. A 49-year-old, non-hypertensive, non-diabetic male. The patient has been started on topical carbonic anhydrase inhibitors for the past 2 years. Open angles, pressures are normal. The only thing that stands out is that the right eye visual acuity is okay, but the left eye has got grossly diminished vision. Now, if we look at both the discs, does anything stand out to anyone? And it's very obvious, the left eye, there looks to be something abnormal going on there. But it's more of a pallor rather than cupping. So now when we go ahead and do a GCC at an RNFL, or a GCIPL and an RNFL, we can see clearly evident RNFL thinning. And if we look at the GCIPL from the Zeiss, we can see that there's gross diminution in terms of thickness. Now, when we do fields for this patient, what we see is, look at the left eye. There's gross diminution of the visual field. Right eye is also affected. But that is very out of proportion to the disc that we were seeing. So once you see something like this, that there is a mismatch between the disc that you're looking at and the visual fields and the OCT RNFL of the GCIPL, you instantly think of something neurological, you have to think out of the box. So we advised in an MRI, and in this patient, the patient had a tumor compressing primarily in the prechiasmatic segment of the left optic nerve and a part of the right optic nerve. So anything out of the ordinary, something that stands out, which doesn't add up, you have to think of something neurological. This is the second case. Now, if you look at this case, this is from the spectralis. The OCT RNFL grossly depressed in the right eye. Left eye looks okay. When you look at the disc, again, does something stand out? And the answer is yes. There appears to be some sort of a pallor which corresponds to the RNFL thinning. So again, when something stands out, you have to do the glaucoma workup. So the fields show a large defect in the right eye. Left eye again is absolutely normal, which is again coinciding with the RNFL. Now, if you have such a lot of pallor, which is probably a segmental pallor, which is corresponding to a field defect, probably it's a case of AION. Now, in these ischemic optic neuropathies, what happens is the superior-inferior asymmetry becomes very evident, especially on the GCC or the GCIPL. So here you can clearly see that the superior half is gone, the inferior half is very well preserved. So something like this on the GCIPL should point towards a neurological cause. Now, BRAO will also give a very similar defect, but in the BRAO, the inner nuclear layer is grossly thinned out. Now let's come to something very interesting, which a lot of the juniors keep asking me. So in this case, it's a 22-year-old engineering intern. Patient has been started on AGM based on the OCT findings that you can see. So a lot of people, when they look at an OCT like this, they immediately think of starting the patient on drops. Now, there is a family history of glaucoma. Father is a known case of PUAG. So the moment you hear a family history and you have an OCT picture like this, you instantly start to think that I should treat this particular patient. But when you look at the fundus of this patient, you can hardly see any cup. It's a myopic disc, it's small, it's tilted, it has a PPA, but it doesn't look glaucomatous. And when you do the visual fields, invariably these patients will have normal visual fields. Just to highlight this point, I'll show you a second case. Again, spectralis, the OCT shows inferior thinning in the right eye and a temporal thinning in the left eye. Patient has again been started on topical prostaglandin analogs. However, there is no family history of glaucoma. Again, if we do the visual fields, it's absolutely normal. So why is this happening? So both of these cases are myopes. The first case had a -5 diopter. The second case has a -6 diopter spherical in both eyes. Now why this is happening is these patients with myopia or increased axial length, they have a decreased image size. So basically, you're measuring the RNFL way away from the disc. So you're getting an abnormally lower value. So due to this, the smaller measured optic nerve width size, it causes an underestimation of the RNFL thickness. That's point A. Point B is, in these patients, the blood vessels and the RNFL, they are deviated more temporally. So that causes a decrease in the superior and the inferior RNFL thickness. Always remember this, that this is deviated more temporally. So there is a pseudo thinning. And if you look very carefully at the peaks, the RNFL peaks, the double hump pattern, they are again shifted. So you have to be very, very careful. This is where the peak should be. This is where it actually is. So be very careful when examining these cases. Now I'll move on to my fourth case, a very, very interesting case. A 24-year-old lady, again a myope, has been on PGA in both eyes. Now if you look at the discs, this eye has an optic disc edema. The left eye had blurred optic disc margins. The pictures are not very clear. Now when we do a OCT RNFL, there is an abnormal thickening. So it's way thicker than it should be. So you can see the zones are in white. If it's in white, it indicates it's above green. That means it's way more abnormally thick. But when you do the fields, it shows a very weird sort of a field. It shows a peripheral scotoma and a central clearing. Now for this very patient, what you can understand is obviously there is some sort of axonal swelling going on. So this is probably a case where there is optic disc edema causing swelling of the retinal ganglion cell axons, which causes an increase in the RNFL thickness, which masks any axonal loss. So to circumvent this, the density of the retinal ganglion cell bodies, that is, you should probably rely on GC-IPL. Why? Because look at this. This is a case of optic disc edema. You can see the RNFL is abnormally thickened, but look at the GC-IPL. It's normal. When the edema subsides, look, the RNFL comes back to normal, but the GC-IPL remains normal. So for any case where there is axonal edema, do a GC-IPL along with the RNFL. Don't rely on the RNFL. Do the visual fields, which will probably show an enlarged blind spot, and do a GC-IPL and follow the patient up. Now, what's interesting is, why is this happening? Because the axons are getting swollen. Now, when you're measuring GC-IPL, you're actually measuring the GCL, the ganglion cell layer, and the IPL. Whereas, if you're measuring GCC, you're measuring the GCL, IPL, and the RNFL. So maybe GC-IPL is a better parameter than GCC. So some machines give a GCC, for example, the OptiView. Some machines give a GC-IPL, for example, the Zeiss. So in high myopes, small tilted optic discs, optic nerve edema, it is good to measure the GC-IPL. Now, in this patient, if there is an abnormally thickened RNFL, I was expecting a normal GCC. But look at the GCC. It's abnormally thinned out. Now, how can that be? Fields show a peripheral constriction. RNFL is thickened. GCC is, again, it's thinned out. Now, when we look at the fundus, we see that this is a case of RP. So it's not just a case of RP, it's a case of RP with bilateral optic disc edema. So always keep your mind open. Don't fixate on one diagnosis, because this case had multiple diagnoses. So it's not a solitary case. Reported, published case studies on retinitis pigmentosa with optic disc edema are there, published in the IGO, in French journals, and all over the world. So around, I think, 10 publications are there. So I'll move on to the next very interesting case. Here you can see that the RNFL is normal, 2017, 2018, progresses abnormally in 2021. So there is this sudden progression. Now, when you have a sudden progression and the discs looks normal, there's something again going on. But the visual fields, again, they were absolutely normal earlier, gross progression. So again, you have to think out of the box, do an MRI. So this was a case of retrobulbar neuritis due to multiple sclerosis. So the MRI showed multiple sclerosis. So a sudden progression, which is out of proportion to the thinning that you see, you have to think of a neurological cause. In fact, the ONTT showed that a case of optic neuritis can present with any kind of visual acuity and with almost every type of visual field pattern loss. So be very, very careful. An optic neuritis can mimic glaucoma. And the last case, a normal optic disc showing normal OCT RNFL, but with a persistent visual field defect. So normal disc, normal OCT RNFL, but persistent visual field defect. Again, you have to go in for a MRI. This particular case was an extramedullary plasmacytoma of the orbit. So be very, very careful when you're seeing a glaucoma patient, because it may not be a glaucoma case. So for the young patients with something out of the box, think of a hereditary abnormality, post-traumatic, inflammatory, or infectious. In middle age, think of a compressive lesion or a vascular event. Elderly, think of something like a GCA. So you have to look out for any signs, apoptosis, a ptosis, a facial asymmetry. Very, very important, loss of any central visual acuity without a loss of peripheral vision, a central scotoma or the visual field respecting the vertical meridian, any pallor out of proportion to the cupping, and RAPD, any conjunctival chemosis or the other signs. So to conclude, younger than average glaucoma patient, be on your toes. Pallor in excess of cupping indicates something other than glaucoma, and look out for the typical neurological field defects that you all know of. Thank you so much.
Thank you very much, Dr. Arijit. That was indeed a very lucid presentation.